So let's talk about a 58-year-old patient with CLL who initially was watched for a short period of time, but then developed evidence of progressive disease. The patient is 17p deleted and unmutated IgVH, developed an elevated white blood cell count, and then subsequently anemia, thrombocytopenia, organomegaly. Required treatment was initially given fludarabine cyclophosphamide rituximab, or FCR, but then progressed, had a complete response initially to therapy, but progressed only 3 years later, requiring retreatment. So initially, if you think about this case, I think about it that it was almost in the era pre-ibrutinib, because initially the patient is young. So when you think about young, fit patients, fludarabine cyclophosphamide rituximab would not be unreasonable. Nowadays, obviously, with the novel therapies, the fact that the patient has a 17p deletion and is unmutated, I would not have given FCR in this case. Ibrutinib, or a clinical trial, of course, but ibrutinib or novel-based therapy would be the approach to take, because again, due to the high-risk features that the patient has, we know that patients who got FCR and were 17p deleted have a short response duration to therapy. So it's really inferior therapy. So a patient nowadays, if they were identified as needing treatment and they have a 17p deletion, they would be selected for ibrutinib-based therapy. In addition, MD Anderson also presented data many years ago that looked at FCR, and when it was broken down by their mutational status, so their IgVH, if they were unmutated, again, another highlight that FCR did not do as well for those individuals who were unmutated as opposed to those who were mutated. So nowadays, again, if you have somebody who has a 17p deletion or who is unmutated, you would probably not give them FCR-based therapy. You would put them on ibrutinib or another novel agent accordingly. Ibrutinib being, of course, approved for untreated patients with CLL, but certainly you can entertain other therapies as they become approved as well. So that's one of the, if you think about this case, is one of the highlights that I think should come out about this case that's significant. The fact that the patient in 3 years also progressed after FCR, again, just shows you the response duration to FCR in a high-risk individual who is unmutated and has a 17p deletion. This goes along with that the response duration is short to FCR, and a novel agent would have been better. So when a patient with CLL presents, and this is always, I think, a little bit up for debate, do you test everything? Do you test their cytogenetics and FISH and their mutational status up front? What about CAT scans? I think there's two ways to look at this. I think that many of us who practice CLL routinely and are in academic centers have the ability to test and get many of these tests covered for. I think if you're in the community and the patient doesn't otherwise need therapy currently, that obviously you need to make the diagnosis, so you need to send flow cytometry and confirm that the patient has CLL. If the patient does not have bulky lymphadenopathy on exam, and nor has a big spleen or liver that you're concerned about, do you have to CAT scan them at initial presentation? No. If the patient, though, subsequently needs therapy, then the testing, I think, has to be done. You have to get cytogenetics and FISH, because you want to know, does the patient have a 17p or p53, because that will change the type of therapy you're giving them. And are they unmutated or they're mutated? Because if they're unmutated, again, you're going to favor not chemoimmunotherapy-based therapy. So you do need to test the patient prior to initiating therapy, at the very least. Whether you test them as soon as they're diagnosed or not, I think there's room, because many of these tests, some of them are, particularly some of these blood tests, can be extremely expensive. And so if that's problematic for the patient, doing that up front, I don't think is absolutely necessary if it doesn't change what you're going to do with the patient at that time. But prior to starting therapy, yes, because having that discussion of, are you going to start ibrutinib-based therapy? Obviously, there's much data that was presented at this ASH that suggests that ibrutinib-based therapy is better regardless. But for those individuals who might want to still give chemoimmunotherapy, if they're favorable patients, mutated IgVH, that discussion can still be had. But you need to test the patients to know that, otherwise you won't know. So those testing do need to be performed prior to initiating therapy on patients with CLL.